last week I was here and we talked about MUE, and we went through the steps of the MUE process. We talked about how you choose what you're going to do an MUE on, whether it's drug dependent or process dependent. We talked about the types of data that you would collect in the MUE process, and when we left off, we were talking about the different methods, and I pointed out that many facilities that you see are going to use the Focus PDCA, and that's not just in the MUE process, but they'll also use that as part of any quality improvement, any performance improvement that you're looking at putting something into play for. Focus PDCA is something that you can use. So there was another method that I pointed out being the SMART problem solving, which you may hear people refer to. And SMART stands for defining the statement, what you're going to measure, whatever analysis you come up with, solution or the remedy, and then test. So that's the same as setting up a Focus PDCA cycle, just a different terminology that you may see. And then the last one is the 10-step method, and again, this is the same thing that is Focus PDCA or whatever it may be, and that's when you're looking at what you're going to monitor, looking at the scope of it, the different aspects of care and service that you may bring into play, determine what your indicators, data sources, and what collection methods you're going to use, establish a means to trigger evaluation. So what that refers to is how do I decide that this is what I'm going to look at? A trigger could be that the patient did or didn't receive a drug. So when we're going in to pull our list, we don't want to look at every patient and try to find a needle in a haystack. So I'm going to look for all patients who receive X drug. And once they receive X drug, that's a trigger for me. You may see this in methodologies such as, I want to look at how well we're managing diabetes care for our patients in the hospital and how well we're dosing their insulin. And a method that I may use to identify those patients, I could go in and say, I want to look at all patients who have a diagnosis of diabetes. That may get me patients who are on oral and IV or subcu insulin. Or I could say, well, I'm really interested in seeing the patients who had difficulty. I wonder how I might look at that. Well, if patients had an event and they received IV glucose, then that might be my trigger for the patients that I want to look at who are also receiving insulin therapy to see what was going on with them that caused them to have problems. So that's a trigger evaluation. You would collect and organize the data, initiate your evaluation of care, and then take whatever steps that you need to improve the care for those patients, and then assess the effectiveness of that, communicate results, and it starts over again. So the point in all of this is that when we do MUEs, it is not with the intention of looking at anything once. If it's worth doing an MUE on, you're going to look at it multiple times, or each time you make an intervention to see if you've had any improvements and to tweak whatever processes, protocols, whatever you may have put into place for it. So now we're moving on to data collection. So the thing about the data collection is you want to think about any influences that may impact the patient population or the problem, whatever it is that you may be looking at. Those influences can be seasonal variations in the types of care provided. I will say that you will likely see some influences based on being in flu season for patients that come in. They're typically sicker. You may have a very high census at that time. Nurses may be taking care of multiple patients. You may have difficulty discharging patients because we have so many. And so the care can somewhat vary during that time of year. Implementation of a new computer system. One of the things that we're getting ready to do at Emory Healthcare is bringing in new technology that the nurses will be using to administer the medications. And so if we're looking at evaluating anything around that time when there's change and people are learning new processes, we would want to at least take note of that. And then we always say in July, when we have new house staff come in. So if you're in the academic medical center environment and you have new trainees coming in, whether those be students or medical residents, there's typically a learning curve that we'll see during that time period as they're learning your protocols and guidelines. I actually say that they may do better in the beginning because they're really trying to stick by the book and do things right and follow the instructions. And then as they get more comfortable, they may begin or further out from training, they may begin to deviate. But those are the types of influences that we would want to know about. Time frame, duration and time of the year. So longer data collection periods lend to better identification of fluctuations in the quality of care. And so if we're going to look at the time period, what I often tell my students and residents when they're looking at a project is, don't just say you're going to look at it from August to the end of the year, or don't just say you're going to look at it over a quarter. If you're trying to limit the number of patients that you're looking at, then one way that you could do that is say, I'm going to do 20 patients in January, 20 patients in the spring, 20 in the fall, 20 in the winter, as a means to have across the year time frame and not just a very small window. And then again, it may not be appropriate to do that. If you're looking at something that's more seasonal, let's get a good example of that. ProFab. Probably doesn't make very much sense for me to look at ProFab, which is anti-venom for snake bites in the winter. I want to make sure that I look at a time frame that's most appropriate for when that use would be. So with data collection, and this is something you want to take note of, there are 3 ways that you can look at data. You can either look at retrospective data, which is actually the most common way that we look at MUE data. This is reviewing the patient's medical records. The patient is gone, they're discharged. There is actually no opportunity to improve that patient's care, no opportunity to make an intervention. This, though, is probably the easiest way to collect data, because if there's information that's going to be there, it's all there and available to you in the record. Concurrent data is typically what we do every day as a pharmacist, and we don't realize it. So this is when you're getting in the patient, you get an order, the patient is receiving that medication at that point in time, but after the first dose is dispensed or administered. This is an opportunity to improve patient care, but it's not necessarily a convenient method to do it. So think about concurrent being, I have a patient who started on vancomycin last night. They've already gotten 1 dose. I'm going in, I'm looking at their lab data, I'm looking at whether or not they've had cultures come back, whether or not they're still febrile, is vancomycin the right drug for them? That's actually a concurrent review. That could be an opportunity or a point in time to collect data. But at that point in time, you can also make an intervention. And then finally, prospective data is prior to the patient receiving the first dose and initiated when the order is generated. This is cumbersome if it's not necessarily automated, and it may result in therapy delays. So with prospective data collection, you receive an order for medication, you're evaluating it against whatever protocol and criteria that you have in place, and then making a decision about whether or not there's therapy there. That's still an opportunity to collect data, even if you're going to make an intervention around that. We use this very often with factor products because when you have patients who come in and they require factor for whatever reason, for whatever form of hemophilia, you want to make sure you're using the right factor, and sometimes they don't need factor at all. So before they need that, we go in and we look at whether or not they meet all the criteria or not. I try to be mindful of the fact that if we're going to be using a factor product, that usually means somebody is bleeding. And so you have to be very expeditious in doing your reviews and conscious of the fact that you may be delaying therapy. So anytime the pharmacists are asked to review things for appropriateness before they're administered to the patient, I sometimes will give pushback on that. I don't want the pharmacist to be the reason that the patient's therapy is being delayed. The way that you can automate that is through your electronic medical record. And so there are some things that we can build into the system to say, hey, before this order goes through, these are the things that, the criteria that need to be met, these are the things that need to be evaluated. We want the physician to go ahead and document or justify why they're using a particular therapy. Then when the pharmacist gets it, that work and that information is already there. That's still an MUE. You still have data collection, and we do collect data around that to go back and then retrospectively see whether all of those things lined up. But that's also a way to do data collection. So, confidentiality and data collection. MUE is different from research in that you will not have enough data typically, or have a method in which you're collecting data that's going to lend itself to some big scientific study that's going to be backed up by statistics. The intention of MUE is for internal performance improvement. And so one of the things that we try to make certain of is that we do it in such a way that is protected and not discoverable. So if we find that we have had a less than ideal way of providing therapy to our patients, that's for us to look at internally and determine how we're going to fix that. And so we have a way that we do it in a protected and not discoverable method, which what that means is that people can't take our MUE data and sue us over it because something happened that shouldn't have happened. Individual patients and practitioners should be identified in some manner other than their actual name. We try to do this as well. I don't think we're as good at it as we could be. And the reason why I say that is the way that we would have done MUE in the past would have been don't say who did it or who didn't do it. But we're moving into this new era of transparency. And so people they want to know how they're performing against others. If we're putting out benchmarks, we may give them their information and then blind everyone else's information so they can see where they fall. But we do try to protect, certainly for sure, our patients, but then there may be practitioners that we blind their information as well. And then you'll want to use your medical record numbers and codes and whatever you can assign to remove the data you're collecting and disassociate it from a person. And so when we're doing MUE data, we discourage individuals from printing off profiles, printing off records, keeping everything electronically, scanning it to or translating it to an Excel file where you've gone in and given everyone unique identifiers. There's different methods you can do, but confidentiality is important. After you've done your data collection, now it's time to do analysis. So the data analysis can be conducted by a multidisciplinary oversight group. For us, that's our system level or local PNC committee. Compare actual performance with expectation. Well, what do we expect to see happen? I'm going to show you all some examples today of when we expect something to go one way and it doesn't. Performance is not meeting standards may be considered opportunities for improvement, and that's the point of it. And then just saying that as you're doing data analysis, that anytime you can use computer software programs, that's helpful. SPSS is a pretty well-known data analysis tool. Most of what we're doing can be put into Excel, and very basic data can come out of that. We've actually also, with our data analysis, started deploying data and analysts to do that work for us. So people who work in that particular space, and we have a newly out of college graduate who is a whiz at that and can sort and splice and dice and analyze data in a way that I could never dream to do. And so if you have access to one of those individuals as part of your MUE program, that's always helpful as well. So once you've done your data collection and your analysis, and you're like, okay, well, what do we do with this? It's time to make an intervention. And sometimes we do MUEs and there's no intervention made at all. That's rare. But there are 3 different interventions that you can sort into. You'll want to make sure that you know about these as well. The first is educational. This is probably the least effective method. And the reason why I say that is because it can never be education alone, where you look for where the knowledge deficits are, you educate, and after you educate, people are just going to start magically doing the right thing. Never happens. The other method you can use is restrictive, which may involve special ordering procedures. I talked about factor products, compliance with guidelines that you have in place. They may have to consult with the specialty. You'll very often see this with a antimicrobial stewardship program where before a specific antibiotic can be ordered, you're required to have an ID consult, have the physician sign off on it. And then, or formulary restrictions, which we use as well. Or it may require process change. So we may have not had anything in place that actually guided what we're supposed to do around that therapy. And so we'll need to change a policy or procedure, implement a new service. This is how several places got to their in-house anti-coag services or their in-house pain management services. They studied the data, they looked at the outcomes, they used that to justify putting a new service in place. Acquisition of new equipment. must be timely. You have to be able to assess the effectiveness of whatever intervention you put into place. Ideally, you should use the same criteria, standard sample, look at it the same way you looked at it before, but there may be some exceptions to that. If you had problems with the original data collection, and you don't put yourself back through that misery, you refine your processes and look at a different way to collect it. If there was a standard or practice change that was associated, so if there were new guidelines that got released, let's say for sepsis, I'm not going to look at my old criteria, I'm going to look at the new criteria. So that would be an exception. Or if there's an opportunity to focus on a subset of your original group. So this would be relevant. Let's say that I was looking at IV acetaminophen administration, and I looked at a broad group, but I found that there was an outlier group, OBGYN, that was the biggest user of IV acetaminophen and the most likely to violate whatever criteria we had in place. Then I may not go back and look at everyone that I looked at in my original NUE. I may only look at that subset of the population, and that would be completely appropriate to do. So now that we've gone through the NUE process, the different steps, what we're looking at collecting, who does this work? Where does it typically fall to? Pharmacy. It usually comes back to us. So what are the various roles and responsibilities? This will vary depending on what practice setting you're in, what the organizational goals are, and what resources you have available to you. We do have some NUEs that end up falling directly to our quality department. DVT prophylaxis, some of the things around C. diff, and the reason for that is because it's publicly reported data that they're constantly on a monthly basis following the information that's continuous NUE. But if we have the opportunity to highlight that through our NUE subcommittees, which some facilities have, then there may be a specific committee that looks at that. We do not actually have that. Clear understanding that the purpose is to improve quality and that each member is expected to actively participate. We are working to get much, much better about taking our NUE processes and not only involving our physicians and we did this review and this is what we found and how are we going to fix it, up to the point of what is it exactly we want to look at, what information do you need us to look at, because we think we may have a problem, what do you want us to collect, involving them and coming up with whatever interventions we have, and then sharing that with them once it's available. So what is the role of the pharmacist? The pharmacist is typically developing the operational plan for NUE. What are we going to look at? When are we going to look at? How does it line up to our top priorities? Working with the prescribers, other individuals, looking at how to determine what you're going to look at and how. Reviewing the individual medication orders against NUE criteria. This is that work I say that we do every day. And then managing the program and the processes. That typically falls under a pharmacist activity. We'll also be collecting, analyzing, and evaluating that patient data to identify any problems that come up with medication use. And this is very often where our students and our residents come in because they typically are looking for projects and we typically need the help with it. And so being very involved with the data collection aspect. Interpreting and reporting those findings and any recommended, any changes that you're recommending in the medication use process, and then providing information and education that based on whatever it is that you come across. So in putting together the NUE process, there are mistakes that can be made or checkpoints to make sure that your program is effective. And so one of those things is authority. We talked about establishing organizational authority to begin with. What's the point of looking at it and making recommendations if you can't make anybody do anything? So the authority is important. Lack of organization, having someone who's over that program and keeping it all bundled up. Poor communication. Poor documentation. So there are different NUEs that we will take on to look at, and we're looking to collect a specific point of data, and it's not documented, so we don't know if they met it or they didn't. We were looking at volume resuscitation, and it'll come into play a little bit for our patients with sepsis, and what we were finding is that they show that they had done appropriate volume resuscitation, which is like the first thing you do. And so the physicians are like, oh, they end up getting all the fluids that they need because we're giving them all these medications, and when you add up the total, they got resuscitated. But there's not a clear indicator that that's been done. Lack of involvement, lack of follow through, your evaluation methodology and PEDS patient care, no delays, and lack of readily retrievable data and information. Electronic medical records have given us a lot of opportunity in this space that we did not have before. So it's good when you can get to the data easily. So that is the end of the lecture. Are there any questions, any clarifications that you all need about that information? Okay, so the other thing that I promised to do for you all, and then we'll be finished, is to talk about some MUEs that we've been taking on at some of our facilities very recently. One of them, and I mentioned last week, was ibupromethazine that we had a couple of students look at who were on rotation. Ibupromethazine, and I may have said this last week, causes issues because of extravasation, depending on how you administer it. And so we wanted to bring it to our Formulary Stewardship Committee to look at it again because ISMP, which is the Institute for Safe Medication Practices, put out guidance last year that all hospitals should take IV acetaminophen off, IV promethazine off the formulary. We did that a couple of years ago, and then prochlorperazine went off the market. And some of the other alternatives, and so it kind of had to come back in because there weren't a lot of alternatives. So we wanted to look at what we were doing. This just gives some background for what promethazine is used for. When administered, the manufacturer says that you want to, that the extravasation is concentration and rate dependent, and also which type of site you're giving it in. So that ideally you would be giving promethazine in a central line versus a peripheral line, because those are very small, and then they also don't have as large of a volume flow, so it gives a lot of opportunity for the drug to leach back into the tissues, which is how you get to extravasation. But they do say that you can give it IM. Sub-Q is completely contraindicated. So there's no proven successful management of extravasation. You stop the injection. You may put some heparin in the location to try to get the drug to disperse. But when patients have an extravasation with this drug, they're usually going to have tissue necrosis, and that can sometimes lead all the way up to amputation of that limb or debridement of that where that administration site was. So pretty serious stuff, rare but serious. So the MUE again was looking at the IV or the ISMP best practices and recommendations to remove from formulary, and we wanted to know what we were doing across the system. Well, this is what we have going on at Emory. We are working very, very hard right now to get to a system P&T where we're doing the same thing across all of our hospitals. And so you can see in all the hospitals listed here, they're all doing something different. So at two of them, they're on formulary, but they're restricted to an attending provider after you've used all of the methods and everything else fails. At one of our hospitals, the method that they use is that we'll keep it and anybody can use it, but we will only do these doses. At another of our hospitals, it's again restricted to a patient who's refractory. And at our hospital up in Johns Creek, they don't have it on formulary, but the anesthesia attending can use it if they need to in the OR, which means that they likely have a central line, so probably not as much of an issue. And then at one of our small hospitals, which Wesley Woods is our geriatric and psych hospital, they don't carry it at all there. And so part of looking at it was getting to a place where we're going to all be doing the same thing, whatever that looks like. So for MUE, what we were able to do was a data warehouse report, and if you are lucky enough to get to a facility that has a data warehouse, you are golden. Data warehouse is a place, a repository where all of your documentation, your financial data, your demographics for the patients feed into a place where you can build and query reports, which makes the data collection much, much easier than going through the charts and manually taking down information. So we looked at ID for methazine for patients from over a calendar year for all of our facilities, and then for Midtown and EUH. And then for St. Joe's, we looked at a different calendar year. I'm not really sure why it was a different calendar year, but that's what we ended up doing. And the current administration for St. Joe's is that the nurse will pull it and dilute it with 10 mLs of normal saline and administer it slow IV pushover 2 to 5 minutes, so speed and concentration dependent. And you can look at the administrations. So at some of our hospitals, we didn't use it at all. At the hospitals where we had the restrictions in place, very little use. And then our hospital that allows it, lots of use. And so what we ended up doing then was saying, okay, for the hospitals where we want to know if they used other therapies prior to going to the promethazine, what were they using? And you can see what's fallen into play here. Ondansetron, which is the same as, which is the drug Zofran, was the most commonly used thing that they would use before they went to prochlorperazine or some of these others and gave the IV promethazine. We had 2 patients who did not get that. And here's a breakdown of the doses that they got. So you can see we were more likely to give lower doses. And then at Midtown, they gave ondansetron every single time before they gave promethazine, with the exception of a patient who had allergies to other drugs, and so they decided to do something else. So we felt pretty confident about the way our criteria was being used at those two facilities. This right here is just an outlier patient that we had who got lots of promethazine, but she had some extenuating circumstances that we wanted to point out. And so from this MUE, the conclusion was that our patients at Midtown and EUH, our criteria, restrictions were followed, and in those patients, there were no adverse outcomes. That's what we want to see. We did have a couple of instances where patients didn't get another antiemetic, but there was usually justification for that. For patients who had more than one, they were using ondansetron, which is usually preferred as their first-line antiemetic. And then the effective rates of promethazine injection was 92% and 75%, meaning that once they gave it, the patient responded to it. And so we felt pretty good about the use at those facilities. For our St. Joseph's facility, and I pointed out that they used, the 848 patients got it, over 2,000 doses administered, 1 patient with an ADR, meaning that we had 1 patient who had extravasation. They were likely to use other agents before they used promethazine. We'll sometimes look at which areas are most likely to use it. So HMS is who came out in this group, and that's hospital medicine. And then GI surgery, which may make sense, and then the ED. So for the ADR that was given, that we had extravasation in, and if we find ADRs, we will sometimes dig into those and see exactly what happened. This was the case where the patient also got other things that could have been suspected or would have been suspected to cause extravasation, although none of these would be as high risk as the promethazine administration. You can see what happens to the patient. They switched arms. So one of the recommendations that came out of this end of year, actually the only one, is that we're going to start looking at how we're going to standardize use across the system and what our response to the ISMP information to not carry it all will look like for us. It doesn't mean that we're going to take promethazine off the formulary. We're not convinced about that yet. We're actually having discussions about not focusing in on the drug, but rather looking at what our antiemetic protocol should look like, and where it fits into that. So it'll likely lead to still some degree of restriction, but seeing if we can't get use down and minimize risk to our patients. So that was one that we looked at. Another one that we looked at was left angiotensin. So anybody in the room know what angiotensin 2 is? New to the market. It's a friend of vasopressin. Actually, maybe it's not a friend of vasopressin, because if you start using angiotensin 2, you should use less vasopressin. Very expensive. We have it at 3 of our facilities, St. Joe's, Midtown, and Emory University Hospital. We added it last year. When we added it to the formulary, we put criteria for use in place, which patients we were going to use it in, and how we were going to use it. So this was an example of one hospital going back to look at what they found as far as compliance to our protocols look like. So here's an example of the protocol that we came up with. We're going to use angiotensin 2 to increase blood pressure in adults with septic or other distributive shock. We were going to start at 10 nanograms per kilogram per minute, IV in a central line. We were going to titrate every 5 minutes for increments up to 15 nanograms per kilogram per minute as needed. And for the first 3 hours, you have a maximum dose of 80. Maintenance dose doesn't exceed 40. And then you monitor the patient through telemetry for their arterial blood pressure, their SpO2 monitoring, and then you also have to do TDT for prophylaxis. That sounds simple enough, right? Like anybody should be able to handle this and get it perfect. This takes a lot of education because the nurses are having to respond to how the patient is responding to the drug and then titrate accordingly. We put titration tables out there, but it's a very high-touch drug to get it right. Should be used first line. We're actually considering it a tertiary agent, so it's used after vasopressin and epinephrine. Should not be used as rescue therapy for moribund patients, meaning if the patient's almost deceased, then we don't throw it on as a last-ditch effort to see if we can bring them back. Patients must have clinical features of distributive shock in a setting of adequate volume resuscitation and cardiac output. This is where that volume resuscitation came up. And then it may be used in mixed shock as long as there are some features of high output shock. So we can look at cardiac index and some other indicators to see how they're, whether or not it's appropriate to use it in the patient or not. As they were going out and implementing, they determined that there were 2 places where they really wanted to evaluate where we were meeting, and that was third line and not rescue therapy. Here are the rest of the protocol and what it looks like if you're the prescriber or the patient, the nurse taking care of the patient. So you titrate up your angiotensin 2, you titrate down your vasopressors or your vasopressin. So we looked at patients that were getting the drug from March 2018 to December 2018. We looked at their length of stay. Remember I talked about what you want to look at from a data collection perspective and only collecting the things that you need. Length of stay, probably important, because if the theory is that if the patient comes in and we use this drug, they get well sooner, they go home sooner. Average norepinephrine equivalents. Adverse events, we wanted to make sure that there were none of those. We looked at mortality. So 7-day mortality, 28-day mortality, were they still in the hospital? When they, if they did die, were they still on angiotensin 2? And then adherence to whatever protocol, the protocol that we put in place. You know, angiotensin 2 is an interesting drug. this drug was studied, the FDA did not require them to prove evidence of such either. There are no head-to-head studies about whether one is better over the other. And so our physicians are of the, in their expertise, of the mindset that if you have a patient who's in the ICU, that the purpose of this drug is to buy you more time to fix whatever the underlying issue is, but that it's not going to directly contribute to their overall outcome, which is a difficult thing to put your head around and kind of justify, because it is a very expensive drug. For us, the cost to the Emory healthcare system as a whole, somewhere between $750,000 to $1 million. And so as we're going back and trying to figure out if we're using it correctly, we're having very difficult conversations around that. So we wanted to look at our adherence to the protocol as well. This is what we found. The ATHOS 3 study is where this was looked at, and this was the patient population. For us, several of our physicians participated in the ATHOS 3 study. So you can see that some of this is reflective of what we would have seen in those patients. And there's the vasopressin, the doses that they were using, whether they were, what the cause of shock was. Very often it was sepsis for us, as it was in the study, and then other types of sepsis, such as multifactorial. And one of the things that we discovered was that we were likely waiting too long to use angiotensin II. Many of our patients had exceeded the dose of vasopressin that was used in the study. So that was something that we were interested in. And then what the causes of shock were. So we went through, the student looked at the demographics, we looked at the indications, we looked at how well they were adjusting the norepinephrine dosing in relation to angiotensin II. So the goal is that once you add that on, then the amount of other drugs should go down. And then this was our mortality. The number of patients we had who actually died on angiotensin II, or within stopping angiotensin II. Our mortality was higher than what we saw in the study. We looked at protocol adherence, adverse drug reactions. It's a high-risk drug in that it requires DVT prophylaxis. The only problem is that very often patients who are that sick may have contraindications to certain DVT prophylaxis. So we have to figure out how to navigate that. And what I talked about in this process, we put a protocol into place, but one of our interventions for this will be redoing our protocol, making it easier for the nurses and the physicians who are doing the titration, and then also identifying that there were some gaps, in that once the patient got up to the 80 nanograms per kilo per minute, which you can do in the first 3 hours, we didn't tell them how to back down to the 40. And so we needed to add that in. And then there were a lot of questions about moribund. So this is always a difficult thing to get into because you start having discussions around ethics, and we as a country generally want everybody to do everything possible. And we often get to this stage and it's very hard to de-escalate therapy. And so there were a lot of discussions about when do we actually define a patient as being moribund. So that was a gap as well. And I don't think that we'll get to an answer to that. I believe it depends on the physician. And I actually think it depends on the family as far as when you define a patient as moribund. And then we had some things about cost. This was the other thing that we looked at. So if we're trying to make sure we're using the drug in the right way, but we also want to be a good steward of our resources, making sure that we weren't wasting any was also important. And what we found was that we were very often having to throw drug away actually got a full bag before, or they didn't make it to their second bag before they passed away. And so that's something that we're going to continue to kind of look at as well. And so we're going to be revising the protocol and updating it. Here's that education that we like as pharmacists, to our nurses, our providers, and to the pharmacy. But I would also say a third step is that we need to figure out what tools we can automate in the system that will bring up the alerts when it's time to do a titration or give better guidance there so that people aren't having to refer back to a specific protocol. So that was angiotensin 2. One more. The other drug that we've been looking at is Exparel. And this I show to you because we are, look, Emory several years ago had Exparel get added to the formulary, but then came up with their own mix of a local block that replaced Exparel that was proven to be just as effective. The reason why they were wanting to get away from Exparel at the time was due to cost. And when Exparel came to the market, there were some concerns that were kind of put out there about it, in that the first thing that it had FDA approval for was hemorrhoidectomy and bunionectomy. And that was it. Yet we were using it in these very complicated surgical cases that didn't have a lot of data around them at that point. And so there was some pushback on using it outside of those indications in very small procedures. They've since gained FDA approval for pretty much all procedures. The other issue that came out around it was around safety. Bupivacaine suspended in a lipid emulsion looks very much like propofol, and it's administered in the OR setting. So the thought was that there was an opportunity for the two drugs to get mixed up, and so there were concerns there. The other reason why it was on the radar was because it came out at a time that we were really beginning to lean into the opioid crisis, and they were promoting that if you use this, you would decrease your opioids that the patients needed to go home. And so for all those reasons, it's been something that we kind of constantly stays on our radar. So this was an MUE that was looking at whether or not it had any impact on our length of stay. Because the goal is that if you inject this into the new knee that your patient gets, that they're going to get up and they're going to ambulate sooner because they're going to have less pain, which means that they can go home faster, whether it's a knee or hip or whatever other joint. So we used our clinical data warehouse. We looked at all patients who got Exparel and all patients who did not. We looked at very specific procedures. So these are procedural codes that you'll typically see in billing. So we were looking at spinal fusions. We were looking at, I think most of this was spinal surgery that we looked at to see what the outcomes were going to be. We looked at our populations that across the hospitals, whether they were male or female, which hospitals were using it, how much of it was ambulatory versus in our surgical centers. We looked at their length of stay for patients who got Exparel, that's in blue, versus the patients who did not get Exparel, which is in blue, versus the patients who did get Exparel in red. So that was the length of stay information. There's more information on their length of stay. So for our patients who got Exparel, their mean length of stay was 4.3 days, versus the patients who did get Exparel was 3.6 days. We looked at the different facilities and if there was an impact there on the length of stay. We looked at the different types of procedures. This goes back to the chart that I had before, and the length of stay versus getting it and not getting it. And what we actually found with this one was that our patients who got Exparel, who technically should have needed fewer opioids, had less pain, and discharged sooner from the hospital, that actually wasn't the case, even if you looked at similar procedures. So how will we use this information as part of our MUE process? We take it back to our surgeons. We take it back to our anesthesiologists. We show them that the length of stay is higher. From there, we may dig into very specific